On our meeting. Hopefully Katie can hear me, and transcription has started, comes up there. Yeah, that's fabulous. Thank you, Katie, and thank you for your support as always for the meeting. Colleagues, Katie will be taking a bigger role in some of the support work for board, and we appreciate everything she does. And just to say that I have authorised Katie to join us at closed board as well today, of course, in an administration and support role. That we're grateful for what we get from Katie. So thank you for being with us, Katie, and for all the support you give us. That's terrific. Okay, good morning, everybody, and a warm welcome to you. Oh, I hope it's a warm welcome to you all, given the temperatures outside. I've mentioned in pre-meeting, I thanked everybody for their understanding in terms of moving. Earlier this week, we made the decision, didn't we, with the weather warning, which has turned into an amber warning, of course. So it's quite right that we meet online. For those of you that have travelled into work, thank you for doing what you're doing. And I appreciate very much that, as ever, there's a terrifically strong attendance here just now. John, have you raised a hand? Did you want to say something, John?
Yeah, just a couple of quick points, if I may, Max. First of all,
course.
Thanks for moving it to virtual, because obviously the weather for me with the dog is pretty impractical in terms of skidding around. And the second issue, is it just worth noting that my understanding is the plan is that April and May are virtual and June is going to be face-to-face. It's probably just worth minuting that for clarity for everybody, Max. Thanks.
Yeah, that's fine. I think I've assumed we're going to go back to the same position. But Laura, had we thought about that? Do we need to determine where we are with April and May?
Yeah, I think that was for the academies, John. So April and May's academies will be virtual, and then June we were looking to do face-to-face. But for the board...
Apologies, Laura, I got confused. I thought it was the board as well. Thank you.
Right. Yeah.
No, quite right, John. We'll make sure there's clarity regarding that today, actually. Laura, maybe we'll just pick that up and we can just be absolutely clear as to where we're going, given that we'll move things around today. That's great. No, thank you for raising that, John. You're quite right to mention it. Okay. Welcome, everybody, to our Board of Directors meeting. Again, thank you for your understanding. And may I realise this is a little habit at the start of meetings recently, but I do want to compliment directors on the superb attendance that we do see at board meetings. There are very rarely apologies, and apologies, of course, are always acceptable. But they are so rare. And indeed, in today's example, where our Chief Medical Officer, Ray, has offered his apologies, he has made sure that there's representation. And John, I can see you're on the call, John Bolton, so thank you very much for joining on Ray's behalf and in the position of Chief Medical Officer for the purposes of today's meeting. But it's sincere compliments from me as chair for the superb attendance we do get at board meetings. We're making decisions collectively, and that's showing by people turning up, being part of it and being here. So thank you, everybody. Can I did thank Katie. It might have been prior to us recording. So Katie, thank you for your support for the meeting. And I do appreciate that we are recording this meeting. And as ever, in the spirit of transparency, we do publish the record of this meeting. So colleagues are perfectly aware of that, I know, and are always appropriate in conversation and comment, but it will be published. Just check the... Yeah, I can see there's a couple of notes in chat as well. So thank you very much for that. Colleagues, now, can I just make sure that I'm looking for... Yes, I can see Pat's name here. And I know she'll be wondering what I'm going to say now, but obviously, I think this is Pat Campbell, our Director of HR. I think this is Pat's last board meeting. And I should have prepared better for this, shouldn't I, in terms of the number of years that Pat has devoted to caring for people in the Bradford area. And I didn't want to get the exact number of years wrong, and if Pat wants to tell us, that's a matter for her. But I know directors and colleagues will want to endorse, I'm sure, comments from the chair, sincerely thanking Pat for everything she's done. She's been a superb Director of Human Resources, we know that, and steeped in so much experience that we've benefited from so many times. And in my 4 years as chair, Pat's always somebody I felt able to turn to talk to in confidence if necessary, and to take wise advice. So I won't get too heavy at the start of the meeting, but Pat, of course, will be a loss to us and will not be easy to replace. And obviously we look forward to getting on with that recruitment process. So Pat, I've said all that on the basis that I've always understood at the end of this month that you're retiring, moving on. Did you want to say a little word to directors and colleagues before we start the meeting proper?
Well, thank you, Max, for your kind words. Yes, it is my last board meeting. I can't say board meetings are something I'll miss. I'm sure I think there will be other parts of my job that I'll miss, but probably board days aren't one of them. Yeah, in terms of years, long time. So I've been 32 years in Bradford, 37 years in the NHS.
Yes.
So yes, a long time. But I have to say that I suppose working in the HR, the things you remember are sort of the difficult people you've had to deal with, or the difficult situations that you've had to manage. But I think genuinely I have enjoyed, working in Bradford. I think it's a great place to work, and I've worked with some really great colleagues. So yes, thank you very much.
And thank you, Pat. I know how highly regarded you are, Pat, inside and beyond the hospital. So, Mel, I should perhaps turn to you as a courtesy as our CEO, and you'll be working daily with Mel, with Pat, with sleeves rolled up and getting on with things. Was there anything you would have wanted to place on record regarding Pat's contribution?
So we're in that time of Pat's career where in the final month there are monthly cycles. So we're going through a lot of meetings where it's the last one. And it's right and proper that we note in every one of those last ones the contribution that Pat has made, which has been incredible and enormous over a very long time. I personally will always be incredibly thankful for her wisdom, guidance, support, discretion, all of those characteristics that are so important in someone who fulfills the role that Pat has done so admirably over that time. I think a real high spot for me, and I think because of probably much of the time that we've worked together being around COVID, was the way that when we had the Filipino nurses recognition day, that it was so evident the love and the respect and admiration shown to Pat by those individuals because of the longevity of the relationship that she had established with those people who had moved countries, come to Bradford, and it was almost like they saw her as some sort of mother figure, meeting them from the airport and settling them in, all above and beyond the duties of a HR director, but testimony to the approach that Pat takes. So enormous thanks, and she'll be very, very missed.
Very well said, Bill. Very well said. Thank you. Pat, thank you for everything. And I can see there's lots of nods and smiles around the virtual table. So we're grateful for everything you've done. And Mel's right, this will be repeated, I think, in 2 or 3 or 4 meetings, but this is the board of directors, and ultimately we want to place on record our sincere thanks to you.
Thank you very much.
Thank you. Thanks very much, Pat. Okay, and for the other thing I want to do actually at the start of this, I know it's always taking a little bit of time at the beginning of the meeting, is just to thank Mel for the time she's taken to advise me of the current situation regionally and nationally in terms of emergency planning and strike arrangements, of course. And that means, exec directors particularly, I think, that I'm aware in the chair that you may have to dip out of this meeting in order to participate in regional or national meetings to help us manage that most effectively. So I am aware of that, and I'm grateful to Mel for bringing it to my attention. And I do know that at times some of our senior colleagues will just have to dip out and deal with that. And I know that you'll be back in as soon as you possibly can. But it's right, of course, that we're present at those meetings. So thank you for that, Mel. And I do realise, colleagues, that you may have some of those additional duties to see to. Okay. Mel, is that okay? Did I articulate that properly? Yeah, that's fine. Thank you. And we did note Ray Smith's apologies, and very grateful to see John here. And I did just want to mention that we do know that Sugra is here with us, but is a little poorly. I think there are some flu symptoms, so we're grateful to Sugra for still dialing in and being here. I think there is a comment in chat perhaps there, but I think Sugra, yeah, may have to drop out. And in fact, she's informed us, hasn't she, that she has COVID. So waiting for a call back from Dr. Sugra, if you can hear me, thank you for your attendance. And I do understand. And of course, your contribution is always superb and welcome. Okay. Thank you. And Altaf, I know that Altaf has been, I think, through to the weather, been delayed returning from a business meeting. I think it was a flight issue. And so Altaf does hope to be able to join us a little later this morning. You see, there's that many people on the list, isn't there? I'm making sure I'm saying that, and he's not actually there yet. He's not there yet. That's fine. So Altaf should be joining us as well. I don't think I've missed anybody or any messages that I would have wanted to share with you. I do want, of course, to welcome other people. I do think we have a couple of governor colleagues who are here as observers. So Faraday and Alex, it's lovely to have you both with us, and you're both most welcome in an observing role, please. So, but grateful to have you here. Ruth, of course, our Insight Non-Exec Director. Good morning and welcome, Ruth, and very pleased you could join us again here today too. So you can, yeah, I can see you can hear me, and that's absolutely fine. Great stuff. Okay. And I do know as well that we have Andrew Mullen, Andrew being our service improvement lead, and Andrew's just going to help us understand better the patient story at the beginning of our agenda. So Andrew, a warm welcome to you, and of course we'll come on to that very quickly. Okay, I won't read through the entire agenda, of course, but just to bring to your attention the usual format that we're going through with the business reports. I'm grateful for the industrial action, previous and forthcoming issues that might arise there at item 8. We'll take finance and performance issues, and whilst it's not appropriate of me to anticipate what directors might think, I do want to commend the quality of the report at item 10. The Health Inequalities and Waiting List is a superb piece of work. There's some amazing information in there. For example, that half of our entire waiting list comes from the 20% most deprived of our communities. And there's two, in my opinion, terrific suggestions for ways in which we might try and deal with inequalities there. So yes, of course, it's to be discussed, and there may be different views around the virtual table, but I do want to commend the authors and those people who put the effort into the Health Inequalities and Waiting List. We'll take our quality and patient safety matters, of course, and as usual, there'll be a strong focus there. Thank you, Karen, on maternity. So we'll pick up on that. And of course, under our people, the usual things are there, the report from the chair, but also the equality, diversity and inclusion strategy, which I'm delighted to see, and Kez will be joining us for that. You'll note that 2 of the 3 Academy reports are under the new Alert, Advise, Assure format. And it's an effort on the part of our chairs and, of course, with our board development to try and draw our attention to the key issues. I promise as chair not to just only focus on the alert. I will give it equal attention to Advise and Assure, but it's a good idea, and I like the way that that's taken forward. We'll deal with partnerships and our audit matters, and we'll hear from Barry as Audit Committee Chair. And finally, there's a matter for approval in relation to the standing financial instructions. Okay. Our 3 annexes are extremely important in terms of the additional information that's in there. I do hope colleagues have had the chance to see them, and may I bring your attention to them as relevant when necessary when we're dealing with matters. The reason I do that very briefly is to ask whether there is any other business that anybody would wish me to take time for today, please. I think if we get through these matters, we'll be content by the sound of it. If anything arises during the time, that's absolutely fine. Thank you. And in that case, knowing what the full agenda is, are there any specific declarations of interest for me to note, please? And if none are declared fine at the moment, that's absolutely fine. Thank you very much, everyone. Okay, so no further comment, I don't think. Anything further to say? No. So shall we get on with business proper and just see if we can pick up this and deal with it all in time? Do notice the chat comments. Thank you. So I'll turn to our chief nurse, Karen, then, please, who's got to introduce, I think, a story that has some resonance. I do know that there are occasional communication problems, and it's the names are anonymous, Stephen and Sarah, but there's some important messages in there. So Karen, may I turn to you in introduction, please, and we'll hear the patient story.
Thank you. So first of all, huge thanks to Sarah and Stephen for sharing this story and taking the time to do so, and doing it in such a way that actually allows us to look at what went well and what went not so well. So I think what we can see, I'm not going to go through the story. Everybody's had it in advance. It'll be with the papers. Yes. What has gone well is the journey and the diagnosis around what must have been very complex and testing times. And I think what comes through also is the dedication of the clinicians that have looked after Stephen and his wife. And there are a number of mentions of individuals, although not by name, where people have gone, obviously, I'd like to say above and beyond, but I think actually people have done what I would want them to do for me, which is a good thing, and it shows that personalised care. And it's often very tricky when somebody presents with multiple things going on and you don't fit into one ology or one specialty. So a huge shout out to the clinicians involved in this care. What is obvious, though, and this is something that as we've discussed as a board with governors in the past as well, is that the way we communicate, in particular around how we give information, either leading up to an appointment or after an appointment, a reliance or over-reliance on digital technology and some assumptions that people are savvy with digital technology and accessible information is something that is a key problem at each and every attendance. So Andrew Mullen's come along. Andrew is a service improvement lead and brought in something called Doctor Doctor. And I'm going to ask him in a minute to speak for a couple of minutes about that. But what I'm also going to propose is that I think this is something that we really need to get our teeth into, and we are doing. But I'm not sure we've shared the journey that we're going on with this wide and far. So, Chair, I'd like to propose that we ask the people in my team that are working on things like accessible information, so Helen in particular, and the patient experience team, and Andrew and some of the digital people to do a session with governors and non-execs, a bit like we do every few months, but focus on this. How do we communicate better? How do we improve? Because one size does not fit all. And unfortunately, how we plan services sometimes in the NHS, we don't quite personalise them, and we try and make one size fit all. So that's my proposal, that we do that. I've got an update on a few of the other bits. So things like the issues with the neurology appointment have been chased up by the patient experience team, and I know that the family are very thankful for that. So I'm going to bring Andrew now in just to tell us a bit about it. And he has got one slide to show a picture of it as well, which I'm sure is better at sharing his screen than I am. Just to talk through Doctor Doctor, and then just have a bit of a question and answer session on that for a few minutes, Chair.
Thanks very much,
I'll hand
Karen.
to Andrew.
Yeah. And Karen, can I just say that thank you for your anticipation there and proposal of a briefing to governors and NEDs. You perhaps wouldn't have known, but a couple of governors did contact me, having read the papers, and said this really resonates, Max. This is the sort of thing we hear about communications issues. So that's a great suggestion and will be well received. So thank you for that. Andrew, good morning and welcome. And shall we pass the microphone to you?
Yes, brilliant. Thanks ever so much, Max, and to everyone else. So yeah, so my name's Andrew. I'm involved because I help bring in our doctor-doctor solution, which is the patient portal. When we think of the patient portal, we're talking an online place where you can have letters, information about your appointments, see a Google map, add it to your calendar, request to change or cancel it online, this kind of thing. So it's definitely not about forcing people online. It's just giving people choice for those who do want to access letters and their information online. It has been relatively popular since we've started, and we have over 60% of letters viewed online. That's over 1 million letters to date in just over 2 years. Saved the trust well over £250,000, and it's running into the sort of 40,000 tonnes of CO2 equivalent. But it's, as we're saying, it's digital, so it's not for everybody. But we're not going down the line of like a checkbook where you're saying, oh, we don't accept checks anymore. What happens is that patients are given the option to view the letter online. The debate might be more around, are we nudging people a bit too much to view the letters online? But what happens is when the appointment's booked and the letter's sent, patients will get a text message and or email if we've got both on file, and that's what's happened here. I'll put the text message in the chat so people can see what that looks like. No, it won't let me. Okay, I will share the screen. So the text message the patients receive looks like this. So it's fairly standard. Great. So it's from Bradford Teaching Hospitals. Dear, pulls in the patient's first name because we might have a mobile number for multiple patients. And it has the fact you can read your appointment letter online. If you can't go online, please reply print. We will send you your letters in the post. So this is what we call a digital by default option, and this may be where some of the criticism comes from, is we're nudging people in the direction of online for the reasons of environmental benefits, cost saving, whereas you could go with a message that says, we've printed and posted you a letter. If you'd like to view it online and change your preference to put to in the future, then you can do. What we've seen with Trust there is if you do that, you get more like a 30% uptake. If you do it this way, you get more like a 60-70% uptake. But the key thing here is if any patients are looking at this and thinking, I'm not sure about this, I think it's a scam, or I can't go online, or I don't engage with this kind of thing, I just don't want to, it's fine. Even if they don't reply print, the letter will automatically print and post 3 days later. And if patients contact the hospital and say, I want my letters by paper, it's a 10-second job for us to just do a little slider to say our preference is now paper instead. So that's how the letters works. Now, what was an interesting point in this story was around why can't I receive letters as an attachment by email instead? And that is a fair point. Now, one of the reasons we don't do that is because that would rely on us having email addresses for patients, which we have 93% of mobile numbers for patients, very few email addresses for patients. It would also rely on us having accurate emails for patients. And even when patients add their own email address into the patient portal, people spell their own email addresses wrong. So it's probably a high risk for staff taking email addresses to spell that. Because of course, if we were to send an email attachment to the wrong email, that's it, the person's got that. Whereas the benefit of having a portal is that when somebody goes into it, they have to verify, either they can log in with NHS login, or they have to verify surname, date of birth, postcode, and then they get a one-time code to the mobile phone. So that just gives us a bit more of a security check. So that's a brief outline. I didn't want to, some of the people on the call will know that if I start talking about digital letters on the patient portal, I could take 30 minutes. So I'll leave it at that and then just open it to any questions.
I did limit Andrew to 2 minutes because, as you said, we all know that he can talk about this, but who'd have thought we'd have had a patient story and ended up talking about, saving the world really with the reduction in CO2 and all sorts of things. So, Max, over to you for questions.
Thank you. Thanks, Karen. Andrew, it's a very well written report, and I'm grateful for you coming as well, actually. So, and actually, you've got the spirit right here. A quick update, quick brief from you, but then you're here should we have any queries or questions or comments we might wish to make. So that's extremely helpful. Thank you. Okay, so I can see there's some comments in chat, so I'm sure people are keeping up with those, and we will of course include them where appropriate within the minutes. But shall I turn to Karen, please? Karen, would you like to come in?
Thanks, Max. So digital experience, brilliant, and you know, we obviously need to do more of that. I suppose my observations are wider than that. So I think when I read through the case study, it's almost care 3, experience 0. So we did a brilliant job of caring, but the people experience, the patient experience was pretty poor. And not for any reason other than inconsistency, and each area having their own little rules and guidelines, and you know, come to this door and go to that door, and so the messaging for me overall was really mixed and caused issues, and simple things like pharmacy not being in the marketplace, so where your shops and restaurants and meeting areas are, which would have made it really simple, and you know, this isn't the first time we've heard about that really. A wider concern about the multiple issues this patient had, but it's almost self-serve, so they've got to go to every different area and get what they need, and I understand that completely, but there's something about how great it would have been if somebody took hold of all those issues and almost coordinated the care in each of those areas, because you know, it was almost, they were left to fend with all this issue, that you know, the wider issues going on. So I think there's just a question for me about the consistency of experience across each of those areas that touched these 2 individuals. And there's a wider point around standing in others' shoes to really understand. I was interviewing last week for a consultancy role, and we were talking about patient flow in A&E, and they put pictures up of really weird things that happen in the hospital, like ward 4 being next to 39 on the ceiling and all those kind of things. So actually, if you walk around the hospital in somebody else's shoes and understood it, we might design things differently. So not a criticism, but just an observation in terms of that overall patient experience.
Thank you very much, Karen. Yeah, well said, Karen. Thank you. And
Karen,
Mohammed, yes,
sorry,
Andrew, yeah, please do.
Yeah, if I could just add to that, yeah. I agree. When I read the story, the digital bit on the end is there's a part of it there, but ultimately, fundamentally, it's a lot of the basics, and I think it was alluded to already, is we often do get that wrong in the trust, frustratingly. Basics around who's printed a letter and they've written one on Word and they've sent an old map and things like that, or just, like you say, taking the time to look at some of the basics of the patient experience.
Thank you, Karen, and thank you, Andrew, for your honesty there, and that's what we need. We need to be open about this, don't we, and hopefully get better. Yeah. Mohammed, please do come in.
Thanks, Max. Thanks, Andrew. Really good to hear about the doctor implementation. I want to build on the points that that Karen was making around the wider picture, really, and digital inclusion. So you're saying 67% of the people will, you know, with the approach that we've taken, will stick with a digital by default approach. That still leaves a third of individuals, and I wonder whether we've done any kind of work around the characteristics of that group that we aren't quite reaching, or don't want to, or can't access the digital solutions. So there's a lot of work being done around digital divide, digital exclusion. Do we have anything around that? The other thing for me is that this then links to the wider piece of work around the virtual BRI ward. And so, you know, that so reaching out to patients and providing a virtual hospital at home experience. How do these 2 things connect together? You talked about NHS login being used by doctor. Are we using the same NHS login for the virtual hospital, virtual ward approach as well? So is there like a single sign-in that we're using across the various different services that the hospital may provide? I'd be really kind of interested in what we're doing there. And finally, linking to the story itself, this kind of experience of multiple appointments, multiple places. We have a national product called Wayfinder that allows patients access to all of their appointments in a single portal. Are we using Wayfinder in Bradford? Is Bradford on one of the pilots for Wayfinder? And where are we in that kind of pipeline?
Thank you, Mohammed. Andrew, please, if you feel okay about, yeah.
Yeah, absolutely. Do you want to come in first, Paul? Or are you in a coughing fit? Do you want to come in first? Do you want me to go?
I'll bring Paul in after any comment you might have on this, Andrew, please, if that's okay. Yeah.
Yes,
Paul, we just touched on it. I get that.
All good points, Mohammed. And the ones that I can certainly know and pick up on are around the digital exclusion piece. So we haven't actually looked at what about the other sort of 30-ish%. We've generally benchmarked against other trusts and find that we're at the top end of digital, and it's almost almost accepted that we won't get to 100%, and it will be a change over time. But it is something we're looking at. We know that, contrary to what people might think around younger people being more likely to engage, we tend to find it's more like the sort of 40s to 55s that engage with the digital more than anybody else. So, but it's on the radar. It's something that we probably should have higher up on the list. The approach we've tried to take instead has been around digital exclusion for how do you encourage people to feel comfortable with it, maybe demo it, having videos that show you how to use it, have a sandbox type thing that people could come into the trust and while they're waiting, have a demo account and say, look, this is how you do it. So when you get your letter, that's what you do. And they could just play around with it in a safe place. So we've looked at that. We've been working with Bradford Council as well with their digital exclusion team to see how, instead of the trust doing it in isolation, how there might be some synergy there where they're going, they could also take things around what the hospital are doing. So there's that. And the other bit that I'm aware of is the Wayfinder bit. So it is NHS login at the moment. We haven't integrated with the NHS app yet, although that is part of the plan. So we can do. We purposely chose not to be part of the initial pilot phase because of the teething problems that you get with these things. So we thought that there's other things we could focus on, let other trusts work out some of the sort of issues and the problems with that, and then we'll pick it up once it's a bit more fleshed out. Because originally the Wayfinder piece was just the appointments, and what we were keen on was we're keen to integrate with the NHS app once it's appointments, letters, other kinds of things, all in one go.
Thank you, Andrew. This is really important stuff. Mohammed, is there anything you would wish to be noted here? I would come back on anything.
I mean, I'm pleased with the Wayfinder that we're integrating with that. That's going to be the national solution that solves some of these problems in terms of a single patient view of all their appointments and letters, etc. So I'd be keen as to where we are. I totally accept your point, Andrew, about it's not always great to be the first wave, because there's a lot of challenges quite often with that, and I totally accept that. But I'd be keen to see kind of where we are in the pipeline. Paul, I'm sure, will have some answers to that. I can respond to a question in the chat from Karen. If you don't mind, Max, I can take that now if you want.
Of course, yeah, please do.
Yeah. So Karen's question was around kind of GPs can send prescriptions to their local pharmacies using an electronic prescription service, which is one of the services that I look after actually nationally in my other job. And there's a lot of work we're doing, Karen, around building that EPS into hospitals. So we've got a couple of hospital sites live with this already. The idea would be that on discharge, you can send a prescription to any local pharmacy, and the patient can be discharged, can go home and pick it up from Boots, independent local pharmacy. So we've got a couple of hospitals, I think a couple in the Midlands now have gone live with it. We're doing a really big push to try and get this integrated. Talking nationally to Cerner and Epic are the big kind of EPR providers, but how we can integrate this further and push this out more. Because I think it would add huge value in terms of flow to the hospital and not waiting for your discharge medicines, etc., etc. So yes, nationally, big issue. We're working on it, and I'll make sure I fly the flag for Bradford and say, can we please try this?
That's really helpful, man. Thank you. Thanks for that detail, Andrew. Thank you for your response. Paul, can I suggest that I give you the last word on this item and maybe just bring Karen in, which might be related to the point that's being raised? So I think we'll listen to Paul as the concluding part of this important item. Our people, our patients, our place. It's all there, isn't it? Karen, please do come in.
It was just in response to Karen Walker, who made a really valuable comment about walking in patients' shoes. So that is a principle we do use. So when we do things like ward accreditation, we do this 15 steps methodology. How does it smell? How does it look? How would you feel? What's your first 15 steps, your impression? The problem is that we are landlocked. So our services have developed over time in places where you wouldn't necessarily have them. And that's really hard. But just to give you some reassurance on that. So as we've developed services, we have taken that very much into consideration. So, for example, The reason that our elective wards are at the top end of the Duke of York entrance is because there's a dedicated ambulance bay and somewhere where you can pick up and drop off early. That's been done on purpose because of that. The work on maternity, so the capital scheme in maternity at the moment, has been developed using women and the Maternity Voices Partnership, walking through each and every area of maternity to say how improvements can be made. So we do use that methodology. Unfortunately, we cannot do everything that we want to do straight away because of that's how the buildings are. It's an old building. You know, a shiny new hospital would be wonderful, wouldn't it? So, but please don't think that we ignore that element of it. You know, it's frustrating for all really, but something that we do take into consideration when we can.
Thanks very much indeed, Karen. That's great. And thank you, colleagues, for the brief comments, useful comments that have been made in chat relevant to the conversation. Some great stuff there about VRI, about do not attend rates, and of course the local prescription service, etc. And Mel's suggestion that perhaps we could think about outstanding pharmacy services here and help with that. So terrific comments, which I'm grateful for. Thank you. This is important. This is important stuff, and was well received with the papers, Karen. So thank you. Let's allow our Chief Digital Officer to have the last kind of word on this, shall we? And pull us together with this. So, Paul, I realise you raised your hand to raise something with us, but of course, perhaps you'd have the last word.
Thanks, Max. And I mean, Andrew set the bar with brevity, so I don't want to over respond, but he's picked up a couple of the items that I would have picked up. So we are actively working with place partners in the context of that digital inclusion agenda, and Sharon Sanders, who leads that work in the local authority, produces a range of resources and materials in the place-based context rather than us starting out to do stuff new and novel. We develop that stuff collectively. I'd like to flag really and really appreciate Andrew around that doctor-doctor relationship, because while Mohammed has identified some of the national assets that are coming online, we are actually in the vanguard of working with a relatively new small independent supplier who is at the cutting edge of some of this stuff. So in terms of our overall program of elective recovery, which colleagues will hear about at a later point, you know, we're actively working with doctor on technologies which would mean that if a patient indicates they're not intending to take up an appointment, we would rapidly invite other patients to drop into that capacity, which would otherwise be unused, and so on and so forth. So I think I would just conclude by saying that at every level, in every appropriate opportunity, we are exploring the step forward that we can make in relation to using digital technology. We have to prioritize those, and we have to, as the story ably demonstrated, balance those with ensuring that those proportions of our population for whom that is not the right way to engage with services and self-direct, because that's really what we're looking for. We're looking to empower more and more of our population to self-direct their way through this. Well, not everybody will be able to or can, so we're always reflective about ensuring that we accommodate that requirement and that need as well. But I mean, ultimately, I always am encouraged by these conversations because I feel like I've got the full endorsement of the board to explore the best of national solutions, the best of partnership solutions, the best of relationships with entrepreneurial vendors, the best leverage with some of the big providers that Mohammed's talked about, who aren't always as responsive as we would want them to be. So yeah, just reassure colleagues that we are actively managing all of the options that we have in front of us, prioritizing and delivering. And even this week, the organization has moved off a very old and very concerning laboratory information management system that has featured on the strategic risk register for some time. Two of our significant services are now on a much more dynamic and newer product, and a product where we're first in Wyatt in terms of delivering on that new platform. So yeah, there's not a week that goes by where we're not actively looking at what contribution digital could make, but also looking at it proportionately.
Perfectly put, Paul. Perfectly put. And I'm pretty confident, Paul, you have the support of all directors to be as outstanding as we can in approaching modern solutions to engagement. So thank you. Thanks very much. And well said at the end there about the proportionality and finding the right balance. But we would want to be modern and outstanding in our approach here. Thank you. Okay, I'll pull this together. I'm going to finish by two quick things. First, thanking Karen for the proposed briefing to NEDs and governors, and of course to anybody else who wishes to attend regarding the work we're doing to make our communications better. I think it's a great suggestion, will be well received, and actually demonstrates just how important this is. So thank you, Karen, great suggestion. That's well received and will be noticed in action when we can get that together. The last thing I'm going to do is a courtesy to Andrew. To say, Andrew, obviously you're sitting virtually among all the directors of the board. We have the authority and the ability to support you in anything you do. So was there anything finally you would have wished to have said in terms of how you would like to see the board support everything you're trying to do with us and for us? It's not a test, of course, but just any message, any final message for the board?
No, for me, I think that having that healthy challenge is good. So it doesn't necessarily always have to be support. I think it's good to have the challenge to keep us honest. So I think ultimately it comes back to the story, which is it's getting the basics right, and it's throughout the hospital getting the basics right. And if we focus on that, a lot of these bigger problems would take care of themselves. So anything that goes towards that, I'm all for.
Well said. Isn't that the perfect finishing line for that? Let's get the basics right. And we mean that, and we embrace that. So well said, Andrew, and thank you. Thanks very much for joining us. You're welcome to stay if you wish to, but I would imagine you've plenty on yourself today in your duties. So
yeah, I'll drop off then, and I'll see you when we come and present something to show you what the portal looks like and show you how it all works.
Fabulous.
Yeah. Thanks again.
Thank you, Andrew.
Bye.
Thank you for what you're doing. And fellow director colleagues, etc., thank you for your contributions there and your the serious way in which you're taking that important issue. That's terrific. Thank you. Okay. Shall we move on then, please? I assume there were no further comments on that. People have had the chance to say, and some terrific notes in chat. Yeah, we see that Andrew's being thanked there. Kevin, thank you for your comments as well regarding maternity and the potential there. So great stuff. Okay. Moving to section 2, which is the minutes of our previous meeting, board meeting, held on the 19th of January. Are there any matters of inaccuracy or amendment, please, that need to be noted? If not, may I ask that we take those as a true record of the meeting in January? Yep, it would appear to be the case. And in terms of matters arising, there are just 2 outstanding actions. Within the report from the chairman's section, so I'll just give you a moment if anybody's wanting to bring up the actions. Mohammed had suggested that could we make recordings of face-to-face meetings and publish those as appear to be well received. And John was going to spend, John Holden, our director of strategy, was just going to take a bit of time and work with colleagues to see whether the logistics of this would allow us for it to happen. John, I think you were able to tell us in January that there is a solution and we hope to move towards it. Is there anything further you'd like to advise directors today, please, regarding that progress?
Yeah, thanks, Chair. I mean, if it hadn't been snowing, we would have been having a play with it today. So we'd have used the boardroom to meet in person, but those who weren't able to, or perhaps 1 or 2 guinea pigs we'd have selected, could have been somewhere else, and we would have had a kind of rotating camera. The technology is called OWL for reasons you can imagine, in the boardroom, which would have been able to pick up colleagues. And then we would have used just bog standard Microsoft Teams to both record the meeting so that even though it was face to face, we had a digital record that we could then put online in the usual way. But it also would have been a chance for us to try out the hybrid nature of the arrangement. So I'm conscious of John's question earlier on, but whenever the next meeting we have face to face on trust premises is, we'll run the pilot then. I mean, I say a pilot, it does feel like this is a ready answer to the challenge we have faced, both to enable hybrid meetings and to record face-to-face meetings. But the the opportunity is there for board members to decide whether they like it or not, whether it works, whether it addresses some of the concerns John had raised previously about accessibility, visually and hearing, etc. So yes, we've done it. Yes, the kit is ready to go, and we look forward to giving it a whirl.
Thank you very much indeed, John. I can see from Mohammed that he's happy with the progress that's being proposed. So thank you for the initial suggestion, Mohammed. And John, thank you for what you've done so far with that. And of course, we would have been trying it out today, wouldn't we? Thank you. And John, you do actually own the second action as well, which was the Green Plan update. But colleagues will see that that's going to be is added to board development for later in the year. And of course, I know that John remains passionate about taking us forward with the Green Plan. John, am I right in thinking there was nothing further to say there, or would you wanted to mention anything?
Well, just to say, I don't think we'll wait till October to engage with the board on this, but I don't think we'd bring it to a formal meeting. More likely, we'd have some work in progress that we'd share online or something.
Thanks very much, John. No, that's noted, and I don't think there's any further questions regarding that. We're pleased to note that. Thanks, everybody. Moving to the business reports. The first of those is the report from the chairman. Hopefully, colleagues have had the chance to read through that. It relates quite a bit to some very good work with governor colleagues. And of course, at item 3, we sadly note that John Bolton, who of course today is here as Chief Medical Officer, has realised that the duties of governor are just a little onerous in relation to combining those with his normal working duties. And so, John, may I thank you very much for what you've done as a governor, and also recognise that the courtesy that you gave in giving us good notice of your intention to step down from that role. John, is there anything you would have wished to say about the role of governors and staff governors particularly?
Thank you, Max. No, and I apologise for having to step down. It really just became more than I could take on, really. Especially as you've made it very clear in the way you welcome the governors and the role they have, that it is a role to be taken really quite seriously, and or very seriously, because of the democratic nature of the organisation and the way it reports to its population. So it was an honour to be a staff governor. It is an honour for whoever takes on the governor roles, and I wish whoever succeeds me all the best. And I thank you for the way in which you welcomed me while I was in the role.
John, to be recorded here at board from me, and of course fellow directors, for everything you did as a governor. It's very much appreciated, and your wisdom will be missed, but you know, we hope and we know in fact that there are some very good candidates, John, I think you're cited on that, who may wish to take up the role. So but thank you, I wanted to say that it's important, and thanks for your endorsement of the importance of governors. Colleagues, my report relates significantly to work with governors, but again, in the spirit of thank yous, which I realise is a lot of today, there's 5 very quick thank yous I'm going to say, because governors and non-exec directors very recently, through the good work of our governance team, have had the chance to meet either in person or through Teams calls our outstanding maternity services team. That's item 4. Item 7, the quality improvement team, and that of course is to do with governors actually having a say in what the priorities should be. And then 3 terrific recent visits, assisted hugely by exec colleagues, through the estate at Bradford Royal Infirmary, at St Luke's, and also with our wonderful Bradford Institute of Health Research. So I did just want to pick out those 5 things, because they take time and they take an effort on the part of senior colleagues to make happen well. And they were superbly conducted and really do offer the chance for stronger decision making and governance through the insight we get. So well done to all those involved in that. Thank you, everybody. You're asked to note my report. Are you content to do that, please? Thanks, everybody. And so shall we turn to Mel? And I do realise, of course, that there is the report from Mel, but should we just give Mel the chance to raise anything particularly she would wish to? Mel, just before I do that, I can see John would like to come in. So, John, shall I bring you in, please?
Yeah, thanks, Max. I was actually going to raise this under closed board, but as you've raised the issue of the visits now, I thought it was pertinent to raise it now. Really, is a question of the future. I thought the visits, particularly around the estates, were excellent, and I haven't had a chance to attend them all, so I don't know what the numbers were. The only thing I'd just like to raise as a question and be assured about is when I went to the St Luke's visit, the numbers were quite small, which, you know, obviously happens. But I just wonder, particularly when we went into the care of the elderly ward, the value added for the staff in terms of time for the small numbers who were there. I just felt a little bit uncomfortable in terms of the amount of time that takes staff away from frontline service delivery for the numbers who were there. And I just think we need to keep a check on it so we don't end up creating a monster, really. Thank you.
Thanks very much, John. Well, I do know that those who attended found the session extremely useful. But I guess, John, are you suggesting that when we do arrange these, we should make as big an effort as we can, perhaps, to get as many there as we can? Is that how you're thinking?
I think that would be one solution, Max, yeah, because I just think it's a lot of time taking staff away from frontline duties. I know we're all busy, but I just had a particular level of discomfort about direct patient care versus visits for small numbers of people. But again, it's an issue for the staff as well, you know, because there will be value added by those visits, but I just want to be assured that there is significant value added, really, that's all.
No, that's a good point. They want to see a good number there, don't they? And that they're having that influence on some decision makers. Thank you, John. Yeah. Julie, would you like to come in, please?
Yeah, agree with John's points. It did feel uncomfortable at F5 and F6 because they were really busy and it felt uncomfy, and we didn't want to waste their time, but great to see them, great to see the services. The only thing to add about the St Luke's site, it would be really good to have a discussion. I don't know if it would be in development or in another forum, maybe if we have any of the non-execs informal sessions about the St Luke's site, because I think what came over was the amount of space on that site, the difficulties with the buildings being listed. And I think Chris, the guy who was taking us round, talked about a plan being developed for St Luke's. So just to flag up here, it'd be really good to understand some of that. And it was almost a plan B of if we don't get a new hospital, but really good visits just to reinforce that, and you know, really knowledgeable people showing us around. So thank you.
Thank you, Julie. Yeah, Julie and colleagues, I always write to the person who's coordinated the meeting to express our sincere thanks, because we get a lot from that. John makes a great point about whether is it fair on the staff when we're traipsing in and asking questions and want to see things. So that's a very fair point. And Julie, thank you for your point there. Julie, on your point about St Luke's, in our closed meeting, we have a decision, I think, to make, haven't we? Yeah, a decision to make regarding St Luke's, which quite properly is not in the public domain just yet as it relates to contractors. And so I've made a note there, Julie, that there might be an opportunity to pick up on any further information we might want there.
Thank you.
Thank you for your comment there, yeah. And Mark, would you like to come in, please?
Yeah, thank you, Chair, and hi, everybody. And just on that latter point, Julie, and I think that was a really good visit, obviously, to St Luke's in terms of the estate, of course. So thank you, everybody that participated, and I hope you found it helpful. Everything you've just described is fully on the radar, and there's an estate strategy being developed that I am wanting to bring back actually to one of the future board development sessions. So I'm happy to talk about it when we look at, as Max has alluded to, at closed board, because yes, there is a lot of estate built in 1852 that's vacant, that needs potentially considering for demolishment, and what we do with some of that space. So we've got full line of sight of, you know, old mortuary, medical records, E block, C block, level 3, etc. So we absolutely do need to put all that back on the table. So I think it's just what I'm trying to do is assure you that it's completely captured on radar. And we will be bringing that back imminently for a bigger, wider discussion on the estate strategy, and it'll include all that. So hopefully that's helpful.
Thank you, Mark. And I did understand it was on your radar. It would just be good to see it at some stage. Not urgent for now, but be good to see it. Thank you.
Thank you, Julie. Thank you for raising the point. Mark, that's extremely helpful as Director of Estates. Thank you very much for coming in there. And so, no, thank you for your questions. Great comments. And Shall we turn to Mel now then, please? We've seen Mel's report, of course, but an opportunity for the CEO to bring to our attention what she may wish to do. So the mic's with you, Mel.
Thank you very much, Chair. So I will take the report as read. There are just two areas that I would wish to highlight, Chair. On the first page, the penultimate paragraph relates to the receipt of the recently published Recovery for Urgent and Emergency Care Services plan, a delivery plan. Colleagues will be aware through my previous updates and those from SAJ and other colleagues relating to the operational pressures that we began to experience very quickly after the Christmas period, that the NHS experienced demands for urgent care, the like of which it has not previously seen, and the consequences of that were very well understood and conveyed through national media. It impacted on every part of the system, whether that be access to primary care, whether it be waiting times for ambulances, and indeed long wait times for beds in our hospitals. And the primary drivers we were familiar with, of course, which was a mixture of an increase in COVID rates alongside large numbers of patients presenting with flu-like symptoms and children in particular with respiratory symptoms. In part in response to that and the acknowledgement that we really needed to plan and transform our services better so that we didn't find ourselves in that situation again. This plan, authored by our new lead for urgent and emergency care at the Department of Health, Sarah Jane Marsh, was received at the end of January. It's a very comprehensive plan. It's one of a suite of three recovery delivery plans. One is about elective care, one is about primary care, which we're expecting to be published imminently, and those together will deal with the three key pressure point areas of the NHS as we are currently trying to deal with demand. For our part, we will take this forward through the access work stream of our Act as One approach. And of course, in that regard, SAJ is the SRO for that. It also houses the A&E Delivery Board and brings together people from across our place, all who have a part and a contribution to play in the achievement of the transformation that will be required in order to meet this delivery plan. So I just wanted to make colleagues aware, and the published report is part of that pack. SAJ is going to come on to talk about in the ops performance report describe the impact that the more recent industrial action has had on the organisation and its impact on patients and their experiences and waiting times, and how we have sought to mitigate that. That was written prior to us understanding that we're about to enter a new renewed phase of industrial action. Happily, over the course of the last week or so, a number of industrial action plans have been stood down. Those from the ambulance service, of course, the scheduled two-day strike of the nurses was also stood down through a recognition of the need to begin negotiations on pay, and also the physiotherapy strike. However, last week the BMA confirmed that junior doctors will be taking industrial action commencing at 7 AM on Monday the 13th until 7 AM on the 16th of March. So a 3-day period. And for over a week and a half now, our strike planning teams have been working incredibly hard to ensure that during this time our patients will remain safe. Consultants whose normal planned activities such as outpatient clinics and routine elective operating will have to have those suspended to allow them to cover the work of striking junior doctors, nursing and other health professions with enhanced clinical skills will be, where possible, able to be redeployed to support the needs of those patients who are in our inpatient wards at the commencement of that strike and will remain there, likely as not for the duration of it. And those attending and being admitted through A&E during that patient period will also need to be catered for in respect of their urgent clinical needs. We hope that we will be able to maintain a small number of planned operations for those patients with cancer and other conditions that require time-critical procedures. Operations and appointments scheduled to occur during that period will be subject to cancellation, and the team over the next day or so will be contacting those patients affected. Many of them who we already appreciate will have waited a long time for their appointments or their procedures, and we apologise to all those patients who might be affected by this. Consultants who are essentially what we call acting down, being expected to fulfil the clinical roles otherwise undertaken by junior doctors, are being prepared and refreshed to do so. As you might appreciate, there are a number of clinical skills that you wouldn't ordinarily expect a consultant routinely to undertake. A lack of familiarisation with some of the procedures relating to those clinical tasks also will need to be taught and support given to consultants to make them confident and able to undertake those. At the same time, we will be looking to align some of those additional allied health professionals and nursing staff with those consultants to support them and in looking after our patients, particularly during the night and out of hours periods. There will be full strike command established internally, as in previous strikes, with exec and operational staff joining touchpoint meetings with colleagues across the West Yorkshire ICB and with regional office throughout the day and up to 10 p.m. each night. And a rota has been put together to ensure that we're fully represented in all of those fora. The impact on the operations of the hospital and all my colleagues, on our patients who were planned to receive treatment, and on their families who will have made arrangements to support and facilitate that, will be impacted, and for all those for whom there will be a consequence, whether that is a wait for an even longer wait for their treatment, a delay to their diagnosis, or an expectation that they are required to work differently in different ways. I apologise, and I sincerely hope and strongly urge that before Monday, both parties in this national dispute can agree to come to the table and negotiate to avoid this strike and its consequences. And I'm happy to take questions, Chair.
Well, thank you very much indeed. Mel, could I just check with you? I think you articulated probably the biggest risk to our patients is that some may find there are longer waits and some treatment delays. Is that fair, Mel? Is that the biggest issue in relation to our patients arising from strike action?
So our primary concern, Max, you will not be surprised to learn, is the safety of patients. So what we are working hard with our clinical colleagues to do is to ensure that although the rotas that we have that require us to have a number of clinical colleagues present, will look very different because they'll have different skill sets, different people on them, that we have adequate coverage to maintain the safety of our patients, and that we also have the ability to respond appropriately to, that's for the patients that we know about, to the ones that we don't know about who may come through the door as an emergency, or those that deteriorate whilst they are already here. So the terminology we use is sort of life, limb and sight. The preservation of that is our imperative, and then thereafter we worry about the consequences of people who have already been waiting, as we know, as the consequences of the pandemic, extraordinarily long times for things to happen to them, whether that's a diagnosis or a treatment to alleviate a long-standing problem. So that's what we are planning to mitigate, and that's what our ops team, strike planning team, have been fully engaged in doing for, as I say, over a week and a half now.
No, that's very clear and very well articulated. Thank you. The safety of our patients matters most. And thank you from me, and I'm sure fellow directors, to all colleagues, execs and beyond, of course, who are working hard to keep our patients safe. So, Mel, thank you. It was very well put. So, any comments or questions arising from the CEO's update, or anything that any matters arising anybody wish to check? Mohammed, please do come in.
Thanks, Max. Thanks, Mel. A different topic altogether, really. I wanted to just pick up very briefly on the recent news about Michelle Cox versus NHS England in terms of a tribunal case that's had a lot of coverage and has had some links to West Yorkshire, because not of Bradford, but because of the place, as one of the protagonists had a role in our patch. Now, there's been some communications from Amanda Pritchard about the changes that are going to happen within NHS England and the actions that they wish to take. And I think this probably relates perhaps to this item and perhaps also to some discussion around EDI later in the agenda. But I just wanted to get some reassurance that we were also listening to the outcomes and from that case, and some reassurance as to we're also taking the lessons on board, because there's some real concerns about the way the grievance was handled and some lessons that some of these matters could have been addressed a bit earlier rather than now kind of following a tribunal.
Thank you, Mohammed.
Yeah, so thank you, Mohammed. Yes, it's a very clearly it's a very important case, described nationally as a landmark case. It is one of many, though, and increasingly, I think there will be more people gaining the confidence to expose ill treatment by colleagues, and that is right and proper, and we would wish to support and facilitate people feeling confident to do so where that is required and they have been affected by this. Immediately that the tribunal outcome was published, steps were taken across West Yorkshire, in that Rob Webster, with the support of all the place leads, of which I am one, wrote to all members of the Race Equality Network across West Yorkshire to reaffirm our commitment to root out racism as an ICB, and in that regard we play our own part, some of which will be referenced in our EDI strategy, some of which is promoted, talked about and encouraged through the work of our EDI Council. So it's safe to say that this landmark trial has been heard and recognised, and we, as well as other colleagues across our place, will embrace the opportunity, and I can see Pat's hand's gone up, to change the narrative, to change the experiences, to change the world as far as our people are concerned in this regard.
Thank you, Mel. And Pat, did you wish to add to that, please?
Yes, so it was just to say that Fahim and I met with our HR business partners yesterday to review all cases that we currently have where there may be an element of discrimination. So that's sort of cases currently being investigated under a disciplinary procedure, under a grievance procedure, under a harassment and bullying procedure. So in terms of doing, having a bit of a case conference, really, the five of us, and looking at whether there was, the case was being managed appropriately, whether we needed to revisit any decision making in those cases. So I don't know if you saw the HSJ, but Roger Klein wrote a very good article a few days ago around HR departments. And we sort of worked through each of those points against each of our current cases. So it's just really to assure you from that perspective as well.
Thank you,
Thank you,
Mel.
Pat.
That is helpful.
I'm going to say, Mohammed, was there anything else you would have wished people to consider? You know, it was the quote, wasn't it, about a pattern of discriminatory behaviours due to the colour of my skin. And that really hurts, doesn't it? Nobody should ever experience that. Mohammed, are you satisfied with what you've heard in terms of our attempts to respond?
Yeah, absolutely. No, it's helpful that, and I know there are some connections to the place rather than to Bradford, and that's helpful that Mel's picking that up at a place level. The only other thing that I think that came out of the case, and there was some discussion about, is about when appointing, I guess, senior roles in particular, but any role in general, that there's sufficient checks as to previous grievances and ongoing matters that should be relevant to future appointments, because many of the parties involved in that particular case got promotions in other areas and had moved on. But Michelle Cox obviously suffered the consequences herself. So that's something else to pick up on, I think.
Yeah, thank you. And I can see Pat nodding there, Mohammed, in terms of those proper person checks that, yeah, we need to be vigilant to that. Thank you. John, please do come in.
Thanks, Max. I just wanted to reiterate, I think, for completeness, a point I raised at Governors, and it relates to some work myself and Karen are picking up related to a case. Given what you said, Pat, I just want to reinforce really and be assured that whilst we're analysing the tribunal cases, can we not forget the issue of how we got there and trying to make sure that in the future we avoid getting to the tribunal wherever possible for the risk, reputation of the organisation and for the improvement of the culture, really. Thank you.
Thank you, John. That seems entirely sensible and in keeping with our position. Pat, would you wish to reply to that?
Yeah, yes, of course, John. And that was, that was one of the reasons behind us doing those case reviews yesterday as a team. So yes, very aware of that.
Thank you. Thanks, Pat. Thank you for raising that, John. Quite right to put that on record. And Mel, did you want to come back in, please? Yeah.
Well, only to emphasise really the approach that we're taking through the staff network. So the resin network, what we want, and these have been sort of reset, recalibrated. They have new chairs. They are being supported to have their voices heard in a much more constructive way than I think we have previously done that in the organisation. And I speak not just for the resin network, but the Enable network and the LGBTQ, and you'll see some of that reported in the council's notes and update. But I think that we can go much further. So it's how we use the networks to influence the decision making in the organisation as well, and to invite those individuals who are part of that network into the discussion and debates that we have about any number of things, so that we see them as a natural partner in what we do as an organisation when we make decisions, how we approach things, and not something that previously has been sort of off to the side. That's my vision for our staff networks, and the resin network is the biggest and most active of those right now. The others are improving, but it's there, and it's got some real shoots of positivity in that.
Thank you very much indeed, Mel. Mohammed, thank you for raising that important case. And can I commend all directors to familiarise themselves with the details of the Michelle Cox case, and perhaps keep it in your mind as we make decisions and we steer the different committees and forums that we lead. So yeah, thank you, Mohammed, very much for raising that. So let's keep that. Let's keep insights on that. Thanks, everybody. Shall I move? Thank you, Mel, for the updates. And shall I move to item 8, please, which is the circulated slides regarding the impact of industrial action, quality of care, finance and performance and staffing. And we can see there the matters that have been brought to our attention, impact, previous and forthcoming likely impact. Should I turn to Sarge in the first place and just ask whether, Sarge, was there anything you wanted to emphasise from that briefing that we've all received? How would you wish to draw our attention to any key points?
I'm just going to quickly display the PowerPoint on screen. Karen's going to start us off with this presentation, and I'll pick up some of the key elements around our approach to industrial action response, and then Pat will pick up some of the HR and comms element to it as well. So if it's okay with you, I'll just share my screen and we can quickly canter through this presentation.
Of course, Saj, yeah.
Thank you. Karen?
Thanks, Saj. So I won't repeat what I said. I was in an actual regional meeting with all the chief nurses when we found out that the RCN strike with no derogation had been called out. So I won't repeat my exact words, but I was very relieved. And I think everybody else knew I was very relieved as well. So you'll be aware we've had a number of days of industrial action following the ballot from the Royal College of Nursing. And during this time, we've got into a rhythm now where there's checklists to be filled in. Our EPRR function is very good at looking and planning for these things, and we went through a series of derogations initially with the RCN, which basically means that agree safe numbers of staff for certain areas that you just couldn't stop. Unfortunately, what then happened after I think 3 national lots of action and 2 lots of action with us, traction wasn't being gained in the eyes of the RCN and progress wasn't being made. So the planned action that was planned for the week before last was with no derogations, which meant that anybody in the RCN could lawfully walk out, whether they were in A&E theatres or wherever that would be, and that was a national position, and the RCN were supporting that. Similarly, the NMC, which is the governing body for nurses and midwifery, were also saying that it's legally binding. They are taking legal industrial action, so there's no other way. They could not be expected to remain in work. So, the threat of a regulatory body isn't a threat at all because their hands were also tied. Thankfully, that industrial action was called off a few days before, and there are now talks around the table to progress this. What we've now, and we can also see that some of the ambulance services are getting around the table. Rail strikes, even though not connected with the NHS, obviously, have also been called off recently. But we have got now the looming action involving junior doctors and the BMA, which we've just briefly talked about. So that's sort of the background. I'll hand over to Saj now to say how we make these decisions, but just to stress, because of the level of command and control that we put in place, that's meant that harms associated with industrial action have been, I'll say limited, but I think what I really mean is that we've had no harms identified as a direct result of industrial action, although harms will have occurred during that period because we know that harms appear at whatever level happen within a busy acute environment. I'll hand over to Saj.
Thank you. Thanks, Karen. So as you can imagine, and as a number of colleagues have already flagged up in the chat around the complexities surrounding industrial action, is that you need a process and a systematic way of being able to analyse all of the information and make decisions. So we, through our emergency planning, response and resilience routes, use the JESSOP tool. So JESSOP is the Joint Emergency Service Interoperability Programme. And there's quite a lot of information available online, and in particular the Joint Decision Management tool, which is the one that I'm displaying on the slide here. And what this tool does is it allows you to bring together lots of different information, reconcile the different priorities, and then try and make some effective decisions on the back of that. And it's a well-recognised model to use. And so how this works is we create a working strategy, which I'll highlight on the next slide. You gather the intelligence. So, for example, we knew about the RCN strikes happening on the 6th and 7th and further strikes from YAS. So we can start building the picture of what's happening, what available information and intelligence we've got. You assess the threat. So you start to understand the risks that are there. to patient safety, and you can then start to establish and recognise any gaps. Once you've done that, then you look at the powers, policies and procedures that exist that will allow you to help mitigate some of that. And then on the back of that, you start to identify all of the options and contingencies that you can put into place. This is where decisions start to come into play around, okay, well, we know, unfortunately, in this case, we might have to step down some routine elective activity, but we've considered that in light of everything else that's happening, and we're trying to preserve the urgents, the cancers, the fast track. So there's a logic to your decision-making process, and it's based on all of the available evidence that you can pull together. You then take the action, and of course, part of this is reviewing what happened, what went well, and what learnings that you can put into place. So we've been using this methodology. We establish a command and control infrastructure each time that there is a strike. So during the day of the strike actions, we have full operational command and control. That's gold, silver, and bronze. And at the same time, we have all of our identified actions in place running concurrently. So the working strategy is about obviously trying to minimize the impact and certainly keeping patients safe. So that's what we intend to do by creating a working strategy. It's about maintaining public confidence and providing reassurance that we're working with our partners and we can continue to maintain safe services. We undertake those actions by having robust gold and silver command throughout the period of the planned industrial action, and we ensure that our patients continue to receive high quality care. And we do some of that by ensuring that we prioritise our patients. Unfortunately, it's not possible to do everything for everyone at that point in time, and that's why we do get into the position of unfortunately having to make some cancellations to elective activity, but we do try to minimise that wherever we possibly can. We also do try and look for early resolution, look to try and minimise any impact through working with the unions. So, for example, with the RCN, myself, Karen, Pat were heavily engaged with the regional RCN meetings in terms of maintaining good relationships with our union reps to try and make sure that we maintain patient safety, but we also respect the fact that our colleagues, our nursing colleagues, will be striking as well, and we're replicating that with the BNA as well under the current industrial action. So that's how we try and establish a working strategy and what we put into play. Karen's already highlighted that prior to and during and straight after an industrial action, we are inundated with self-assessment checklists, which is a necessary step, really, although they're very onerous, is a necessary step in being able to collate all of the information from individual organisations at regional and national level to understand what the impact is. Internally, we will look to understand the impact at individual service areas. So we ask colleagues in our CSUs to try and identify the issues that they're going to have and to mitigate those issues ahead of time. The purpose of command and control is not to is to pick up issues that are occurring on the day. It's not to sort out issues that we could have anticipated and put into play. So we then have our gold, silver core planning groups, and as Mel's highlighted, now for the junior doctor strikes, we've been meeting pretty much daily, all day for the last week and a half now as a strike group, and there's core colleagues involved in that. And then we will seek wider executive support to what we're doing, and that therefore becomes a position whereby there's full executive oversight and colleagues help with different elements of that. And we feed into the West Yorkshire ICB command and control infrastructure as well. And in fact, there is a meeting later on today. So there's one at midday that Mel's joining. There's one at 2 o'clock that I'll be joining as well. And out of that then comes the operational response plan, which we then keep as a live document. So that's how we manage operationally. I'm not going to spend any amount of time on this particular slide. Mel's already highlighted the junior doctor strike that is happening next week from the 13th through and including the morning of the 16th of March. So at that point, I'll hand over to Pat to take us through the HR elements, and then I'll give you a flavour of the activity impact we've had to date.
Thanks, Saj. Okay, so the BMA position of no derogations has undoubtedly made strike planning more difficult. You know, when we think to our strike planning for the RCN. So the only time that the BMA will consider a derogation if it is a major incident or a mass casualty incident, and then that has to be escalated up to NHS England, and it's a decision NHS England and the national BMA would take. So that's sort of been the background to our strike planning. We've held a number of industrial action meetings with the BMA, most laterally last night. The meetings have tended to focus on what the consultant rate of pay should be, as covering for a junior doctor and covering the junior doctor strike action is classed as extra contractual work. So it is fair to say the meetings have been difficult, and we've sort of got to a agree to disagree position re-rates of pay. But dialogue, we have been clear that dialogue remains open with the BMA on that. Obviously, in terms of planning, as before, we have, in terms of practical things, there is no new annual leave booked, study leave, all essential meetings have been stood down, and detailed specialty level plans are being developed. In terms of the actual strike days, again, we have sort of made practical arrangements with the BMA. So there will be 2 picket lines on the BRI site between 7:30 and 1:30 on each day, and no pickets on any other site. So just moving on to communications. Obviously, we do have a detailed communication strategy, and have been sort of through global emails and very detailed FAQs for staff who choose to strike and staff who are not striking. We're also quite clear in terms of sort of support and helplines, again, for people who need any additional support at the time. And I think we've also, I think Karen mentioned at the start, obviously comms to patients and the public as part of that. So I'll move back to you, Saj.
Thank you very much, Pat. Yes, that's right. So we are keeping obviously a track of what activity impact those strikes have had, and what we've included in there is the impact of the strikes thus far. Clearly, we are tracking through the impact that the junior doctor strike will have for next week. We've done a full analysis of the number of patients we've got booked, and we are going through those waiting lists to understand which patients we unfortunately would have to cancel, and we will start to contact those affected patients. But just from December's position, you can see there, I won't run through them, that there's quite a lot of detail which breaks down into the different categories, but we were able to maintain 80% plus of the outpatient activity. We did see a bigger impact on theatres simply because of the numbers involved there, and also the fact of our heavy reliance on the nursing workforce within theatres environments. And similarly, we've done the same for the February strike action that took place as well. So that's all we wanted to highlight, Max. Of course, we're happy to take any questions. We just thought it was important to give you a flavour of the work and what we do and how we manage a strike action day and the subsequent impact that has.
Guys, thank you so much. That's an extremely useful briefing, and can I compliment the quality of the slides, which took into account the different features as well, communications, impacts on staff, and indeed impacts on patients. Thank you for everything that's being done there. Colleagues, the purpose of that was to bring to our attention the way in which we're trying to manage this emergency situation. And so may I just check whether are there any queries, questions, matters that might arise, please? No? Great. We're well briefed, and that's extremely helpful. Saj, Pat, and team and colleagues, thank you very much indeed. A really useful briefing. Great stuff. Okay. Shall we move then to our finance and performance issues, please? We'll hear from Julie. We've got a terrific paper on health inequalities and waiting list analysis. We're going to hear about the financial and operational plan, and we're invited to approve the capital programme. Well, the nature of the approval that's being sought is that we delegate that to the work of the Finance and Performance Academy. I'm thinking in terms of time, shall we try and take these matters within the sort of half-hour period, and around about 12 o'clock, hopefully get the chance to stretch our legs and get some hot drinks and keep ourselves going and refreshed. Okay, so we'll try and work to a half-hour time scale for the finance and performance issues. Carl, thank you very much for joining us. I hope you can hear me okay. Delighted to have you here, and terrific paper that's been circulated among colleagues. So, Carl, welcome and thank you.
Thank you.
Great stuff. Good. I'm glad you're here. But I think it's sensible probably just to orientate ourselves, to turn to Julie and just ask whether colleagues, of course, have had the two papers from January and February from Julie in her position as chair of the F&P Academy. But Julie, was there anything you wish to just emphasise to us, please?
Okay, so I'll be quick. So we've got time to have the discussions on the agenda with the additional papers we've got, all which we've seen updates on through the Finance and Performance Academy. You've got two reports. The February one is the new style report following the development session we had as a board. It's intended to be shorter, more concise. It's intended to tell you a little bit more about how the meeting felt. So Karen and I have adopted these reports, and this is our first month at doing them. So at some stage, it'll be good to think, do we think they're better or not? I think my reflection on writing was, it was better. We could pick, I know in the next meeting, what I'll be picking up as I go through the meeting to include in the report. So like I say, the report talks about how it felt, and it talks about me feeling it was rushed. It's probably rushed because of the content we have in the meeting. You know, we've got 3 other things on the agenda, and we had other things on the agenda, and actually we could spend 2 hours on the waiting list, health inequalities. We could have spent 2 hours talking about it. Great work. The other thing I have to commend is the kind of quality of reports that come through Finance and Performance Academy. And I've got to say, you know, what has changed in them over the years I've been chairing the Academy and my past experience of F&P is the improvement thread that comes through everything we see. So we're doing the assurance piece, we're reporting against strategic priorities, we're managing our risks, but really what's really great is that improvement thread, and we see it through every report we get, and the reports are continually being strengthened by the authors to pull in that improvement. Really great to see. So I think it's important that I note that about how did the meeting feel. We'll continue to develop those reports, and like I say, not necessarily for feedback now, but it'd be good in one of our development sessions at some stage to say, do they feel better? So we're trying to listen to that feedback. We're trying to listen to the conversation we had as a board about how we want to improve. There's a good report on aligning the conversation to our strategic priorities. So I don't need to tell you reporting on our strategic priorities. It's there. You can see how the conversation aligned to those strategic priorities. One thing to add before I move on to the reports, I talk about in the red section of the new alert report, the finance run rate deteriorating. And I know, Max, you fed back on that, but unfortunately, reports have been published. What's important to say is if we look at our finance is for this financial year, and we look at the totality of the year, we say we're going to hit our break-even target. If you break that down into the months that are happening now, what we can see is the financial position is deteriorating and getting tighter. And we'll see that reflected in the financial plan discussion. So what the run rate does is looks at individual months and how it's going, rather than look at the totality of the year. So you look at the totality of the year and all looks fine. But what we can see is that tightening, and month by month, that position is getting tighter. We're managing it this year, but we'll see when we look at the financial plan how that starts to deteriorate the position. I'll pause there, Max. So I know we've got some good reports to follow.
Thank you very much, Julie. It's extremely helpful. So colleagues, you've seen Julie's report, and those of you that attend Finance and Performance Academy will know how well Julie picks the meetings up. And great point, Julie, about the improvement line that's that's improving, that's increasing with the work we're doing. So, and that there's a lesson for all of us there, perhaps, about keeping focused on where we're getting better, where can we get better. Good stuff. Were there any questions, please, for Julie? And if not, shall we turn then, please, to the item 10, which, well, I'll just simply pass to Saj, shall I? You know my views on this. I think it's extremely important. I'm delighted at the nature of the work that's been done. And can I say as chairman, and this is important to contextualise this into, I know that we don't have the ability to immediately get everything right, the solutions for everybody. It's a difficult position. But what I'm delighted and commend about this work is that we're at least seeking to understand where some gaps might be, and then think about, is there anything we can do to begin to address those? Many of it, of course, is beyond NHS purview. I get that, but this is good stuff. So in that context, I will turn to Saj, and thanks again for all the work that's been done here. Saj, with you, please. Oh, you're just still on mute, I think, Saj.
Apologies, I have just pressed two buttons just to make it worse to come off mute. Yeah, thank you very much for those comments, Mark. This is indeed a lot of work that Carl and his team and colleagues in Paul's team helped with in pulling together. But I think the insight Carl brings to this and the systematic approach he uses is fantastic. What we're doing is providing an update to board together. In particular, the focus is on the waiting list analysis aspects of health inequalities. And in the operational plan for next year, the ask is about tackling inequalities on three fronts: outcomes, experience, and access. And this very much focuses in on the access elements of this. Obviously, earlier on in the year, board received an update, initial findings from Carl's work, which colleagues found really interesting. So Carl's going to describe how we've been able to progress that. And of course, board colleagues will be aware that we have already taken practical steps, particularly around learning disabilities, both from a identification of patients coming in with learning disabilities onto our waiting list, but then also in terms of the practical prioritization of those patients. And we took that decision as a board to be able to prioritize patients through. So the interesting things now will be to look at is, so as a result of making those changes, are we demonstrating that we are able to make a positive impact or not? And because this is an iterative process, what we're doing is, as we go through the waiting list, our analysis is getting more in depth, our intelligence is getting better, and therefore that's leading to the next questions, which then say, right, as a result of that, the so what of how are you going to resolve that? Some of this is for us absolutely to sort as an organisation, and some of this is for us to be able to take into the relevant place-based groups, whether that be through access meetings or whether that be through any of the other Actors One programmes, to see how we can collectively work upon the solution. So that's all I'm going to say. Carl, I'll press the buttons on the slides. You just tell me when you want me to move on. So I'll hand straight over to you.
Thank you.
Thank you. Yeah, and thank you everyone for the opportunity to present this. If you jump to slide 4, Saj, the context we've covered quite a lot of it actually, and I had presented this previously, but just in terms of the work that we're doing, we know in Bradford by postcode there's a variance in healthy life expectancy. We know from the national data that deprivation is linked to health outcomes and health inequality. So we had that context to support some work in terms of, well, what do we do going forward? If you look at slide 5, we were tasked, but a task we happily took on board, which was to start using the data items available to understand more about our waiting lists and the access element of outcomes, experience, and access. As we go, you'll notice it becomes more difficult to keep isolated to access, because that's not how we do it. We learn stuff from this, but then we link in with outcomes and experience and talk to services and clinical teams. And it all becomes one conversation. But I'll try and keep to the stuff we're doing on access and its iterative cycle. The next one, in terms of the approach, this was the approach as I see it from what was in that 22-23 objectives, which rolls into next year, which is about using data collaboratively, collectively to take some action, but to use that action to inform improving the data and keep cycling around. And in doing that, reduce health inequalities. Now, that approach isn't just for access, that's for experience and outcomes as well. But in terms of access, we really took this on board. That's what we want to do this year. I think from experience, there were some reports came out from other trusts, some reports have come out nationally that had done some aggregate analysis that I felt was difficult to understand if it really told us anything. So I feel like what we've done in terms of our cycle, in terms of using it, is try and work out what things tell us things and what things create a bit of noise that you have to move past to understand more about your waiting list and access to your services. So that's what we're doing. That covers off this, and I think there's a couple of slides which describe just that, using the data items. So I'll remind us, so we've been using IMD, so the indices of multiple deprivation, ethnicity, learning disability, alongside data items that are already in our patient characteristics, age, other data items. So we've been doing that, and then looking at how we do waiting list analysis already, and trying to put the lens of Core 20 onto that analysis. And as I say, it's an iterative process that's teaching us, one, how to do the analysis and what to look at and how to view the waiting list, but also giving some insight for conversations with clinical colleagues around, well, actually, what might we need to do in response to some of the things we're seeing. So that's the approach. So you can dive into the sort of what are we seeing. I think I've spoiled slide 10 by describing the methodology already, but as I say, you have seen this one before. What I will draw out is, since the last time I presented, I have repeated the analysis, but I have added to the analysis some more detailed work on DNA rates. We've started to look at referral and referral trend patterns, and we've also looked at treatment data in a lot more detail. So what we know, half our waiting list is from the 20% most deprived areas as defined by Core 20, and that's fairly consistent across all time bands. On average, Core 20 patients do wait 1 week longer for their first outpatient appointment. So I presented that last time. And if you remember, when we looked into it, there's quite a strong link there between the referral priority and that wait time. But what you definitely see is an impact of DNAs. And through the second cycle of analysis we've done, that hasn't changed. So the impact of DNAs remains important as part of this thinking. So when you look at a routine referral, a fast track referral, or there is an increased likelihood that those from a more deprived area will not attend their appointment. And that is consistent, and it's still there in the data. And we identified where some of the gaps are. But we did notice it didn't correlate to the whole gap. And some of the gap is you're just much more likely to be on a routine referral. Sorry, Sajid, it's the next slide. I'm going a bit quicker, aren't I? So you're much more likely to be on a routine referral and much less likely to be on a fast track referral. So we wanted to have a look at that, and that's some of the stuff we have started to have a look at. And then what we did see, so if we go on the DNA deep dive side, that's the next one. So within the DNA rates, and this is the stuff that I've new to the meeting, stuff that wasn't here last time. At an aggregate level, so looking at DNA rates, there isn't a correlation between ethnicity and the DNA rate, particularly within Core 20 and non-Core 20. There was some at a specialty level. So the odd example where we can see an increased likelihood of a DNA rate by ethnicity, and we're exploring that with those service areas. That's given us insight to go and have a clinical conversation to try and understand more. There is a really strong correlation between DNA rates and age. So you are much more likely within the more deprived areas to DNA if you're younger than if you're older. And that was a really strong correlation we could see. So we can start to see that if we're doing some targeted DNA reduction work, if we were to do that work in services that are heavily represented from more deprived areas, and we did that work with the younger population of that area, that would have the biggest impact overall in terms of reducing DNA rate and reducing the impact DNA rate might be having on access, and therefore might be having on outcome of healthcare. So, and we shared that information internally with some of the work we're doing. We also took it to Actors One to have a look at it at a place level. And there's a slide later on which shows some of the stuff that's happening in response to it and will continue to happen into the new year. The other bit we did, we looked at the treatment data we've got. And what we could see is patients from the more deprived areas, fewer ultimately end up being admitted for treatment. Now, in part, if we go back to what we already knew, lower representation on a fast track referral, higher on a routine, and actually the overall likelihood of being admitted from a routine is less than a fast track. So there's some correlation to, or there is a correlation to that initial referral priority. So the work we're doing in terms of referrals and are people coming in on the right priority continues to be a line of inquiry. But what we were seeing there was that position. Once once a decision was made to admit, typically, so for the majority of cases, the clinical priority within a treatment function didn't seem to change by core 20, non-core 20. So you're as likely to be a P2, P3 or P4 at that point, with some exceptions. So we could see for skin cancer, we talked a bit about skin cancer last time, and it's something we're exploring, and we've been, with the clinical colleagues, we've been looking at some of the national documents around this and around prevalence. So but we could definitely see you are much less likely to be referred, treated, and a P2. So if you were from a core 20 demographic. So it's certainly something to continue our lines of inquiry on. Interestingly, something new that we hadn't seen in the first bit of analysis, any real hints of, was for both gynecology and urology cancer, you are less likely to be referred, but if you are referred, you're more likely to be admitted and more likely to be a P2. So we're starting to look into that. We don't want to draw conclusions from it, but it's interesting, and it will have us looking into, are we getting referrals from that community for that type of cancer? And if we are we getting them early enough? Because it's giving you a hint that potentially we're getting either under referral or late presentations. Yeah, exactly. So I try not to jump to the conclusions, but it leads you to thinking about what that might be, and we're exploring that much with the clinical team to see what needs to happen in response to that observation. We also know, so this is beyond this presentation, but this is just to show we're not in isolation. We know from the cancer experience data, so we do the patient experience surveys, we break them down by IMD as well. So we know already that core 20 patients have present or tell us they have a poorer experience of cancer pathways than non-core 20. So there's this connection between the sort of experience people are having and action we're already planning to take and things we're starting to observe. So we want to look in parallel. Like we've seen these things in terms of gynae and urology. What are we seeing in terms of the experience, and can we do one thing to support the patients going through those pathways? Sorry, Seb, there was a little bit more on that one, because in the routine referrals, which are really high, there was some, if you removed women and children's services, which is a high number, which may make the aggregate position look fairly even. Actually, if you looked at the other treatment functions, you could see the routine referrals from core 20 are much more likely to remain a P3 or a P4 treatment rather than be a P2, which you wouldn't quite expect as many P2s from within the routine cohort. But you actually do see some of that for some of the outlying areas, the higher IMD score areas. So there's something to look at in terms of the sort of the presentation. But again, it's a lot of this, and one of probably the biggest thing we've learned is priority, so either referral priority or clinical priority, and treatment function matters so much to how long people will wait that you have to include those before you start looking at anything else. And if they carry so much weight in terms of the algorithm for how long you'll wait, that it's the analysis has to be done within those groupings. And so we went on to have a little bit more look at referrals in a minute. So the key findings in terms of where we're at the minute, so we know you're more likely to be on a routine pathway from core 20, you're more likely to DNA, you're less likely to be referred for cancer. Once you're looking in the referral priority and beyond the DNA rates, you are there is very little difference in terms of access that we can see. There's a real strong correlation, as I say, between referral priority and increased DNA rates. And then we couldn't see, as you move through the pathway, the data, once you break it down by priority and treatment function, gets smaller. So I've got to be careful in terms of how firm I am with the what I'm seeing, but we couldn't see any evidence of variance in clinical prioritization. So if the decision is made to admit, you're as likely to get the same prioritization code, and you are likely to be given a TCI at the same time, irrespective of demographic and IMD, sorry. So, which is a positive, but equally, the feeding us into some of the clinical conversations, actually, because we know outcome can be, not as good for certain population, and we also know from some of the national models, people have built algorithms, including some of these things. Are we clinically considering the deprivation score within that clinical prioritizing process? And I think the data says we probably aren't. It's probably not part of an algorithm at the minute. Where it should be is a conversation to be had. But I think that's the thing at the minute, it doesn't look like it forms part of that decision making. So the question for us would be, well, should it? Some places are doing that, some places aren't. So it's really good in what it's showing in terms of data. Yes. In terms of referrals, I looked at this in a lot of detail, tried to get underneath it. The problem with the referral data by GP practice area and what we hold, there's just it's so noisy. There's so much going on. You can't grasp any firm, pattern or trend. So I haven't actually seen anything in the referral data which lets me think there's something happening that we can investigate further. Now, I think the best step here is to work in partnership. So from conversations with people from the Research Institute or with partners at Act as One, I think beyond hospital, there's a wealth of referral data and intelligence that would give us more than I can currently get a hold of. So that's my next effort, is to work with partners to try and understand more around referral patterns. And as I say, I've left 2 questions that I really did want to explore within this last cycle. I never really got around to fully answering, which is around those ones where we're seeing high representation and low representation. Do we think that's right? And can we see anything which makes us think it's not? So that's that. So the next step of the presentations are just a couple of examples of things we are doing in response to some of the stuff we've got. So we have been for some time now prioritising patients with learning disability within the individual waiting priority groups. So prioritising first outpatient, and then prioritising as a P2 against other P2, P3 against other P3, etc. So I've described that. We can definitely see, and again, when you do it by treatment function, because what you're referred for will have as big an impact, on your wait time as anything. When you look at it within treatment function, the time to first outpatient is shorter. What we can't see, because the data gets so small in terms of treatment, is whether or not it's shorter for treatment length, from decision to admit to treatment occurring. But we can see that week on week because we've got the data every week through the access cycle. We're making sure that the treatment is expedited for patients who haven't got a date yet, in the order of LD first, then the rest of the P2, LD P3, etc. So I can see that happening. So I'm pretty assured that it must be, but there's not enough numbers to show you in the chart here yet. Part of that, we think, is we haven't necessarily got all of the patients who are on Waddy Love's data set for learning disability with an LD flag, as we do on our system, to tell us that this is a patient to prioritise. So we've built a report for that. We've now got a Power BI report which is telling us all of the patients who maybe could have an LD flag who don't currently have one, for the clinical teams to have a look at and action. So I think as we progress that data set and we get more patients identified with the LD flag, we'll be able to see a bit more data that I can then prove the system's working. And we're going to build that into weekly reporting through ops as well. The other piece of work I've highlighted is something Actors 1 we're looking at. So this is around reduction of DNA rates and reduction of DNA rates for paediatric patients. But what they did in kind of to advance on what we could already see in the data, they talked to these community groups and they learned more about the reasons why. So the data we can do is say this would have a benefit to do this work, but what you can't do the work without working out what to target, what to do, how to improve patients' experience and the patients and then reduce the likelihood of a DNA. So that's exactly what they did, and they worked with the groups to understand more. And we will now target through the actions off the back of that work to how we reduce DNA rates for this cohort, knowing it's a cohort that actually, if we did reduce the DNA rates, will, what's the right word, not disproportionately, but it will have a bigger impact on the overall gap between core 20 and non-core 20 wait times because of the high volumes of core 20 patients in this cohort. And then we'll repeat this for other priority areas identified through the high volume of routine referrals, the high volume of DNAs against those referrals. Quickly got a next steps, which is very much around continue to refine the data. We're still doing a lot of this ad hoc, but we've just moved into the world of building lots of the waiting list analysis tools into Power BI, all of which we're doing with this lens, which is brilliant. So because we're rebuilding how we're doing this analysis, we're building it with this lens in mind. So it'll become much more routine. And when it is, it'll be available to services to use themselves. And I think having learned what things have power in terms of the algorithm, we can help and describe to others how to use the data presented to them and not perhaps make some of the assumptions other organisations have around where they're at, but to help them refine how they look at it and use it. And again, to extend the DNA work, which we know is going to be impactful, and then to work in partnership with others around some of the data items we don't have. So that's the next steps. Thank you.
Carl, that is a fantastic briefing. Thank you very much indeed. It's quite clear that you've got this and you've got a passion for the subject. I do want to commend you on everything you're doing here, Carl. You're a senior colleague, and the work that's been done here is superb. We know there are no easy answers here, and there's some challenging stuff. But isn't it a great reflection on us that we're trying to at least understand it and articulate it, and in fact adapting to the needs of our community? And that's what's apparent here in analysing, accepting, sharing, taking it into partners and places, and the proposed stuff. The two projects on LD and paediatric DNAs, in my opinion, are superb, but I recognise directors may have a view. So, but Carl, it's important. This is really, really important stuff, and can be lost sometimes. It was a point colleagues share with you, a point made by the regional director, Richard Barker, who said how important tackling health inequalities remains, and he pleaded with us not to lose that with the current difficulties that Sarge and Carl will be well aware of constant things coming in from top. Achieve this, achieve that, tick this box, tick that box. And so I do want to commend the work that's being done here. I will open up for questions and comments, and perhaps start with you, Karen, please.
Thanks, Chair. I mean, it really is an excellent piece of work, but it also makes me think, oh, what else? And then what other work are we doing that we're not capturing and we're not showcasing as well? So this is very much around those elective type pathways. We know that we have things like maternity services. So we know that only, I think it's about 50–60% of our women book for the first maternal appointment, the booking appointment within the agreed timescales or within the set timescales. I think it was reduced from 13 to 10 weeks recently. We know that COVID vaccination and flu vaccination uptake in our city, especially in our inner city areas, is not what we would want it to be, and is one of the worst uptakes, definitely in West Yorkshire, if not in the country. So I think there are other areas that we need to also bring into this evolving presentation that we do, because I think we see this every few months, and it's really good to keep seeing it. But I think there's other bits of work we can put on there, and we can also say what we're doing about some of these things. So, for example, we know for people with LD accessing services, we've recently launched a red rucksack scheme, not to be mixed up with the red bag scheme, which is for something to do with care homes. So any person registered on our system with an LD, and we have that flag and that's been described, has got the option of being provided with it's a big red rucksack. It was done after consultation and discussions with people with LD, and in that is the VIP passport, any aids, fidget toys, blankets, or any special things that person requires are in that bag, and all staff will recognise how important that bag is to people, because we know things like there was a sad case where somebody's sippy cup got lost on the transfer from A&E to a ward, which meant that somebody then was drinking out of a normal cup and aspirated and got a chest infection. So there's absolutely loads of stuff that we're doing to tackle these inequalities, and also our staff awareness of these inequalities. In maternity, a lot of is being done around poverty. So the opening of a food bank in maternity, the way we've put in free phone numbers for people to access services. So there is lots of other work going on that we can showcase as well. So again, I feel like a broken record today. I keep saying, and maybe we should do a board development session on this, but I think there's so much stuff that we could talk about that we probably don't have time to talk about in board, just to offer some reassurance, but also to spark some discussions to how we could make things even better.
Thank you very much, Karen. I'm proud to work with the chief nurse who endorses this and indeed suggests an expansion of it to look perhaps for the more hidden areas. So that can completely agree. Laura, let's pick up as to whether we can get some board development time and on this, because I recognise we all know that we all care about this, don't we? We're all sat around a virtual table knowing we could spend all day talking about these things, and perhaps we should. So, Karen, thank you. Paul, please do come in.
Yeah, Max. I mean, I'm delighted to follow both Carl and Karen in this context, because actually, they've nailed the balance for me and the criticality of the relationship between a deeper curiosity about what we think the numbers tell us, and then a real actionable step that says, well, in light of that, this is the difference that we're going to make. So I don't really have anything else to add, because I think it's one without the other is unhelpful, because you go running down blind alleyways, or your partial solutions from a less intelligent piece of analysis, or you get completely consumed with the curiosity of what the numbers are telling you and forget that they actually ultimately relate to real experience. And I think my two colleagues have absolutely nailed the way that we are blending those things currently and aspire to blend them further and deeper to the future. So I'm really proud to follow those two presentations.
Thank you, Paul. Well said. Thank you. Julie, please do come in.
Ma'am, just to reinforce, great presentation. We had some conversation in F&P about so what, not so what because it's so what, but what are we doing about it? And we were reassured about some of the work that was happening as a consequence of seeing it. So we were already on and doing things with the kind of insights we'd been given. So that felt really good. So just to reinforce conversation, great piece of work.
Thank you, Julie. Delighted to hear academies are thinking about this as well. Yeah, good stuff. Thank you. And Mohammed, please do come in.
Thanks, Max. Just want to echo what others have said. Great to see this focus on this area, and great to see the presentation. Just a couple of things to pick up on. One was something in the presentation towards the latter end about that building on that connection of most of the NDAs are correlated with being younger. Sorry, not NDAs, DNAs are correlated with being younger, and therefore digital may be a solution to this. I think there's something to think about there in terms of, yes, people who are younger tend to be more kind of digitally native. However, they can have other challenges that perhaps are not immediately obvious. So they may have the devices, but they often struggle with data. and data is very expensive, and it's worth perhaps thinking a little bit about how we may address or be just cognizant of challenges around data. I think I've come across some examples where some of the apps can use a lot of data very, very quickly, and you don't realize. So that's something to think about. Just taking a step back from this particular area, but liking the idea of the core 20 focus, I wonder whether we've done a similar analysis or could do a similar analysis on two further areas. One is around our serious incidents. So something we've talked about quite a lot in Quality Academy has been around the obvious connection between inequality and quality, and you can't get quality without addressing that inequality. And we've done some work around communication barriers in language, etc., etc. But I wonder if it would help us to get a deeper insight into that by how many of our SIs affect populations in that core 20 cohort, and that would take that knowledge of our attendances and build that through a hospital and looking at kind of adverse outcomes and seeing if there's still a connection and a correlation there. And then the other thing is about how many of our staff population are from that core 20 background. And because that would be a really useful insight as well to try and understand, because that's the core population that we're trying to reach as well, but also we recognize there are some real challenges for that population. I wonder whether we've done any kind of analysis or understand how many, is the core 20 population reflected in our staff? Are they overrepresented? Are they underrepresented in our staff? And what are the challenges that they face?
Understanding our people. Yeah, very well put, Mohammed. Thank you very much. And Sergeant Carl, there's no pressure on immediate responses, of course, unless you were going to say no way. We'd perhaps want that debate, but the idea here is that comments are being made, and we'd ask you to consider these things. Of course, if there's any obvious response, I'll come back to you. Sergeant John, I'll make sure you've got the last say on all this. John, would you like to come in? John Bolton, please.
Hi, thanks, Carl. It is an amazing piece of work that you're pulling together, and I think actually, in a sense, you've hidden the complexities that you're dealing with here to make it palatable and understandable to the rest of us. I'm aware from where I used to work in Bristol before I came up to Yorkshire, and there's a national research project that's been running between Bradford and Bristol for at least 20 years, because I was peripherally involved in it back in 2002, looking at prostate cancer and the socioeconomic and racial / ethnic differences in the presentation and outcomes of people with prostate cancer. And it is incredibly complicated because, for example, amongst Afro-Caribbean men, they have a much lower incidence of prostate cancer. So you'd expect to see fewer referrals. But the biology of prostate cancer in Afro-Caribbean men is different than that is in Caucasians. And so when they do present, they tend to present later and with worse disease that's more aggressive and has a poorer outcome. And that's one aspect of one disease. And the more local to Bradford, we have a lower incidence of prostate cancer in Asian men. Some of that is because ethnically they're protected, genetically they're more protected from this disease, but also because prostate cancer tends to affect older men, and we know the life expectancy of our ethnic minorities is reduced. And so sometimes it's because they're dying of something else first. And so focusing on the prostate cancer is the wrong thing. We should be working on what's killing them earlier before they get their prostate cancer. So all I was trying to illustrate is that once you start to get into disease pathways, it gets incredibly complicated. But what is really good is you've picked up on some things which are patently actionable and self-evident, like things like Mohammed mentioned our SIs. There's no reason why we should expect one group to have more SIs than another, or DNA rates, or waiting times once you get on the waiting list. So those are things that definitely I think are worth putting a lot of effort in, because we can probably make a big difference pretty quickly if we did.
John, that's a fabulous clinical perspective. Thank you very much indeed, and indeed for your support of the idea of the analysis. So great stuff. Thank you, John. And Saj, shall I bring you in, please?
Thanks, Max. Yeah, and one of my points links directly to what John just highlighted there, and then I'll pick up the point around DNAs as well that Mohammed made. This is why having the data and linking it with the clinical intelligence is really, really important. Because when I saw that data originally, my natural inclination was, oh, this is urology patients coming in, late presentations. Is this a cultural issue? Is this people seeking help later on because of cultural sensitivities that exist around urology, for instance, in certain communities? And just simply being able to explore with clinical colleagues whether they believe that to be the case, or actually know the clinical disposition is such that certain communities are more prone to certain disease, is a really good way of understanding where you put your focus in, because otherwise your natural response might well be for prostates, for instance. I know it's very specific for prostates, and there's lots of other things which might be cultural that we need to look at. Could be you spend a lot of time trying to go down that angle, whereas in reality it's not the actual thing you're looking for. And as John says, concentrate on the thing that ends up leading to the worst outcome in the first instance rather than that. So I found it hugely helpful when we were having that clinical debate and analysing the data. In terms of the DNAs, we definitely need to look at that. And I think you're right. I mean, I hadn't appreciated, Mohammed, the apps and the data heavy nature of some of the apps. It hadn't occurred to me. So that's a really important point that we'll pick up on. But this is where the link to the doctor-doctor tool that we were talking about earlier on comes in. One of the things that we're going to try and pilot, and we were doing discussions just literally earlier this week, is we get lots of short notice cancellations coming through. And at the moment, the process is really manual and laborious, where individuals then have to try and go through a manual process of picking the phone up and ringing people to book slots, as opposed to an automated message going out to certain people on a waiting list to be able to say, are you more available? And there is potential that actually, if you're younger, you're in a core 20 population area, you might just be able to, whereas you might not know what you're doing in 6, 8, 10 weeks ahead. If that's where your appointment, you might find, oh, hang on, this fits with me because I'm happening to be in Bradford, I'm at the uni, or I'm in town, I've had an appointment notification through, I'm going to accept that appointment tomorrow. And there's win-win there, win-win for us in terms of utilizing capacity, but that otherwise would have gone wasted, but a win-win in terms of we try and get another way of bringing in colleagues, patients who could well have DNA'd. So we're picking that up as well, Max, but it's just one angle and one aspect of the work we're trying to do.
Oh, somebody got a dog in. Karen. Thank you, Saj. No, thank you very much. Saj, there was just the one point, wasn't there, raised by Mel as she had to leave to go to the national meeting about primary care colleagues and whether they're perhaps engaged in some of this analysis, discussions, etc. And what do you think? Is it one to move to, or is it
no,
now?
Definitely no. I think it's very much at this stage has been data mining when it comes to the referrals. What we need to do with that data now that we've got a good level of intelligence from that data is we need to push that through, a bit like Carl was saying, through the groups that we have already got established under Actors 1 to say, we're picking up this discrepancy, we want to bring it to your attention, how can you help us? And that's real sort of us using partners and partners using us in terms of understanding the data we've got and then doing something about it. So that's the next stage that we pick up on that.
That's fantastic, Serge. Thank you very much indeed. And thanks everybody for the comments. And I do note the terrific comments in chat as well. Look, I know it's already a long day and there's no way I wanted to rush this because this particular bit of work makes me feel proud. On a serious note, you can imagine as your chairman, I go to national and regional meetings and I'm constantly hearing that tackling health inequalities is what leads us. And here we are as a foundation trust really taking this on, really genuinely analysing it where there are no easy solutions. So it makes me very proud of the work we're doing here. Carl, thank you so much for what you're doing here. I've picked up on, I'm going to start thinking about outcomes, experience, access. What a great threefold way to think, actually, of things. If that's where we're seeking to tackle health inequalities, outcomes, experience, access, brilliant. Mike, Cal, the only final point I would have wanted to say, and thanks everybody for contributions, I will of course bring you in, is have you thought of sharing this analysis with our health research team, perhaps through John Wright? It struck me that Connected Bradford, and this would at an open board meeting, this is in the public domain, Connected Bradford would love to see A, what we're doing, and B, to perhaps work with it in terms of steering some of their research work. With you, Cal.
Yeah, so certainly, and there has been conversations with colleagues from research in terms of how we could do additional things in the future. What I actually wanted to come in on, going back to the outcome experience access, and thank you for the kind comments of this piece of work, but this has really just been trying to bring access up to where outcomes and experience already probably are. So going back to Karen's point, people are doing stuff on this all the time, learning from patients and what people tell us. I think the access bit was probably a little bit behind, and we've caught it up. And that's really, and as I've been doing the analysis and talking to teams, you're finding out stuff they're already doing that matches what you're seeing in the data. So people know some of this stuff already. It didn't need the data as such, but it's been reassuring. It supported some of the stuff people were already planning to do or doing. So that was what I wanted to add to the.
Thank you, Cal. That's extremely helpful. Thank you. And Mohammed, would you like to have the final say on this item? Thank you.
Well, thanks, Max. I just wanted to pick up on the last thing you said about Connected Bradford, Max, actually, because I was going to raise it in my Quality Academy update, but it's pertinent to raise it now. I met with Tom Lawton, Vishal, and Mike McCoo over at the research unit this week. In fact, I went to see them this week, and we had a really good discussion about exactly this topic, about Connected Bradford, about how we use the data, what more can we do with it, and how do we connect it with kind of delivery of care across the place in the region. So it links perfectly. So I think what Carl's talking about is it's happening and some connections already being formed there. We wanted to have a further discussion about the Improvement Academy in the research area and the Quality Patient Safety Academy and our quality improvement work, and how do we connect that more. So I was having some early discussions with Vishal and the team about that. And I know there were also, Vishal's doing a review, which John Holden will know about, in terms of the OMS program, the outstanding programs and how they work and all of that. So I think there's definitely connections. There's more we can do, but yeah, it's working really well, and I'm pleased. And the Connected Bradford seems the obvious place to kind of build on.
Thank you very much indeed, Mohammed. Thanks for your endorsement of that, actually. Yeah, we've got great research colleagues here, haven't we? So terrific. Thank you. Yeah. And Paul, please do come in.
Yeah, Max, I'm conscious I'm keeping people from a much needed break, but I just wanted to reiterate that we're picking up a topic in the private board about the thing called a sub-national secure data environment, and just to give Mohammed and colleagues assurance that in the context of routine and regular dialogue with John, Tom, Vishal, the whole team at because actually the brand is a sort of family brand, because one of the other things that I think it's worth colleagues probably having more visibility on at a later point is Born in Bradford, Connected Bradford, BIHR as an entity, the Improvement Academy. There's lots of sub-strands of the capability and expertise that we've got just across the car park. And I think the important thing is to identify the right relationship purposefully for the right end. I'll reiterate that a little bit again later on, but yeah, I could just completely again endorse the fact that there is a lot of value, and we are gaining a lot of value from that relationship becoming increasingly closer.
That's brilliant, Paul. Thanks very much. Colleagues, thank you for all the efforts you're putting into this. What an outstanding demonstration of our attempts to tackle unequal outcomes. And I've really enjoyed the discussion on this. Carl, thank you so much for everything you're doing there. We look forward to joining you on next steps. And in fact, I think it was our chief nurse, Karen, who suggested, let's get some development time together and in perhaps a more informal circumstance, talk through how we're doing this. But I'm proud to see this being done. Well done, everyone. It's great work. Yeah. Okay. Terrific briefing, great ideas on next steps, and obvious engagement with us all. Shall we take a break? I say what, shall we just make this, I know it's my job then to bring us back on time, but let's get 15 minutes in here, yeah? So I've got 12:20, 12:21, 12:35, we will resume with the final two items on finance and performance, yeah? So let's take 15 minutes, which I hope gives people time to grab whatever they need to do. See you at 12:35 to resume.